our country today is access to health care. If they don't have coverage, they're worried about it. If they do have coverage, they may be underinsured. If they're not underinsured, they still may be worried that job loss could leave them in a situation where, because of a pre-existing health condition, they could not get insurance if they fell out of the present insurance policy that they have. So the bill advances access to insurance through insurance reform. It then deals with what would be unacceptable premium increase by making certain that you have universal coverage, which brings then into the risk pool the younger uninsured that are a great component of a spreading of risk across the entire population. But to the extent then you bring in universal coverage, you need to make some subsidy available so people can afford the premiums that can't otherwise afford the premiums. And if you do that, then you need to find a way of paying for it, hence cost savings and revenue increases. So within that conceptual framework of the bill, I think the bill advances in a very substantive way extraordinary health reform. Where I fault the bill is in a couple of places. One, the fatal flaw of using Medicare rates for the public plan option, which in an underpaid area that I represent would simply compound the unfairness of the existing Medicare system. But, and this gets to the final portion of my question, Mr. Elmendorf, I'm worried about system delivery reform that, in my opinion, is insufficiently attended to in this bill. I believe this bill wimps out on system reform. I want to quote to you a quote from the MedPAC chairman, Glenn Hackbarth, that appeared in today's paper. He apparently gave this quote at a June hearing. Quote, "The health care delivery system we see today is not a true system. Care coordination is rare. Specialist care is favored over primary care. Quality of care is often poor, and costs are high and increasing at an unsustainable rate," end quote. Now, even looking at the reforms advanced in this bill, well, first of all, do you agree with Hackbarth's assessment of things, and is that assessment changed substantially by the bill before you?
So, Congressman, thought your initial characterization of the contours of the bill sounded just right to me. The bill makes a profound difference in health insurance coverage in this country. I think that MedPAC's view, as expressed in this latest quotation, but also over time, that the health care system, particularly the Medicare parts that they study most closely, are beset by inefficiencies, is correct and shared by a wide range of health experts. I think the challenge that is faced by the drafters of this bill and all people who are trying to improve the efficiency of the health care system is that the state of understanding among experts is not sufficient to prescribe the precise changes, exactly who should be paid more for what, under what circumstances, or paid less for what, under what circumstances. The understanding is not sufficiently well developed to prescribe that with great confidence that it will be prescribed correctly. In my view, one of the strengths of this bill, as it's drafted, is that it establishes demonstration projects and pilot projects in a variety of ways, a variety of areas, accountable care organizations, primary care physicians, medical homes, patient shared decision making, and so on, that will add to the knowledge base and enable more reforms later. But it is true.
Let me ask you on that point, Mr. Elmendorf. Do you think, I agree with you. In fact, I've authored the accountable care organization component. But do you think that perhaps ultimate universal adoption of some of those reforms would be more likely if the executive branch was giving a little more authority relative to studying innovations and then applying those innovations that advance quality care, but in a more cost-effective way?
Yes. So I was saying that, but I think there are ways that more vigorous action could be taken in the legislation. One is to grant greater flexibility for the HHS secretary or the CMS administrator to move payment policies in new directions as evidence comes in. I think it's, again, a lot of health experts would agree that micromanagement of the Medicare program by the Congress slows the process of learning and adopting what has been learned. There are also other possible changes that could be made that would have, I think, tend to reduce health spending. One would be changes in the cost sharing in Medicare. Another would be changes in the tax exclusion for employment-based health insurance. And as you know, we've written on a variety of places about a menu of options. Of course, the choices are yours. We don't make, in contrast to the MedPAC, we don't make recommendations. But there are other options, I think, that are on the table. But the challenge is very acute, and I don't want to, as I tried to explain to Congressman Davis before, I don't want to downplay the effort that is made here. That's a different question from asking whether the effects of the things that are in this bill will offset $1 trillion or so of additional federal health spending in an effort to expand insurance coverage.
Thank you. Thank you, Mr. Chairman.